Namaste and good morning, everyone. Myself, Dr. Sunil Gupta, President of Diabetes and in Study Group in India, Diabetes and Pregnancy Study Group in India, DIPSI. Welcome you all for this very important meeting. Vicky, can you just mute yourself?
Yes.
I welcome you all for this very important meeting today. This is a Prega Talk. This Prega Talk is basically meant for people across the country, across the continent, and it is for public awareness. It's a public awareness platform where DIPSI, the National DIPSI, which is one of its own kind association, a society, which is dealing with diabetes and pregnancy since more than 3 decades now. It has its own research papers across this part of the world, and they have their own guidelines, which has been accepted and promoted and has been published by the Government of India guidelines for management of gestational diabetes. So this DIPSI group is a very cohesive group, which is aggressively involved in the research and the public awareness campaigns. Now, this Prega Talk is one of such kind that we have the program every Wednesday from 6 to 7 p.m. And we experts from across the country. This is possibly happening for the first time in the history that we are doing these education programs on different languages of different regions. We started with the interview of Dr. Sheshaya on 30th of January. And from there onwards, in various languages like Punjabi, Gujarati, Marathi, Bangla, Hindi, Marathi, Assami. Then we had in Telugu, Tamil, Malayalam. Then we also had in Sindhi language, then Bihari. And very next, today is in English. And very next is going to be in Kashmiri language. So we are aggressive in getting, we have around 22 languages which are official languages of India, and this is our 16th program, and possibly the next is going to be 17th language, and we are trying to cover almost all the languages which are there in our constitution. So today we have this awareness program of Prega Talk with very prominent personalities with us. They're all our teachers. I'll introduce them one by one. We have Professor Dr. Ashok Kumar Das. Dr. Ashok Kumar Das is from Pondicherry. He's the ex-dean of Jipmer Medical College, Puducherry, and he is presently the professor and head of Department of Medicine in one of the medical college in Pondicherry, which is a Jipmer Medical College, and he has got keen interest in teaching his students. Basically, he's a teacher of teachers, and he's one of the pillar of this DIPSI group and has contributed a lot for this society as a whole. And also he was a deputy director of health and has worked very closely with the government of India in Delhi as well as in Tamil Nadu and Puducherry. We welcome you, Professor A.K. Das, sir. We also have none other than internationally acclaimed personality with us, Dr. Anil Kapoor, who is the international chair of WDF, World Diabetes Foundation, and is still one of the key having a very key post as one of the trustee or one of the director of the WDF, and he represent India as one of the very important part of management of diabetes and pregnancy, and he has floated a lot of projects in Uttar Pradesh, in Madhya Pradesh, and various parts of the country, and they have become few of the pioneering research work with the support of WDF, which is a global health society which is working for the research and well-being of diabetes across the globe. And these projects have been brought by none other than Dr. Anil Kapoor. He's again the past president of DIPSI, and he has consented to be. It's very difficult to get him. Sometimes he's in UK, sometimes he's in Bangalore, and we are fortunate enough that at this particular moment he's going to speak from Bangalore. We welcome you, Dr. Anil Kapoor. Then we have Dr. Piki Saxena. Dr. Piki Saxena is a very young, dynamic researcher and a obstetrician gynecologist from Lady Hardy Medical College, Delhi, and she holds a position of one of the professor there in the Obstetric and Gynec Society. She has got wonderful original work in very young age, and her work has been recognized and published in very high quality journals in India and international journals. And she is also a governing council member of DIPSI. We welcome you, Dr. Piki Saxena from Delhi. I have one of the nutritionists with me. She is none other than Dr. Kavita Gupta. She is the head of the Department of Dietetics from Sunnis Diabetes Care and Research Center, Nagpur, and she is also she has recently done her PhD last year from Nagpur University and has got keen interest in gestational diabetes and is one of the popular faculty in most of the DIPSI programs across the country when it comes to nutrition. Not only DIPSI, but even RSSDA platform or Diabetes India platform, any platform we see when you talk about gestational diabetes and diet, she's one of the part of it in such meetings. So we all are there to basically educate our people and make them aware about diabetes and pregnancy. Now, sir, I being a president, I'm trying to give a welcome address. I'm trying to come across with concluding remarks in most of the CMEs which have been taken in different languages. And but still, we had already completed almost 15 programs. There's a 16th program, but I personally feel we still need a lot of such awareness programs for the benefit of the masses as a whole. And to start with this, why is it important? We say that diabetes and pregnancy are very important for doctors, for those who are pregnant women. But why, as the whole, everyone in the society should be aware of it? And what is the prevalence? How many people in the country we have? What is the global prevalence of gestational diabetes? Why this has become a public health issue? So may I ask this question to Dr. A.K. Das, something about the how much prevalence, how many women they are more prone to have GDM, and what is the gestational diabetes is, and why should we be little be concerned of it? Sir, you're muted, sir.
Thank you, Sunil, and my sincere greetings and regards, Dr. Anil, and my close friend and Dr. Piki Sangshada and Kavita. Dear friends, I'll just start by saying what is exactly gestational diabetes mellitus. Dear friends, it is a condition in which a woman did not have diabetes before, but develops diabetes or high blood glucose during pregnancy. And this, by definition, should disappear after 6 weeks of delivery. But normally, we do not do that, should be doing that test. But we'll take the definition as the diabetes the lady had never had before, but during pregnancy, she develops diabetes. That is what is called a GDM. And usually, after 6 weeks of delivery, the diabetes disappears. Now, coming to the prevalence, means since the time is short and we all have to speak at least three rounds each, I must tell you that the prevalence of GDM is almost equivalent to the prevalence. You might be knowing, my dear friends in the audience, some condition called impaired glucose tolerance. That is not diabetes, but the precondition of diabetes. Now, it is in India is about 17-18%. So in our country, we have the prevalence of gestational diabetes as high as 17.7-18% in one of the very famous study of DIPOP study. But it is a range. The range in the country varies between 9% to 21%. Some people from the Kerala and other parts have showed even 24% because the diabetes in Kerala is also very high. So I will say that the prevalence is about 17 to say about 20%. The median
I didn't catch that.
Could you try again? The median prevalence is usually 3 to 9%, as per many world literature, 3 to 9%. But in our country, we have more number of mothers developing GDM. Now, coming to the why it is important, there are four aspects. One aspect is the fact that this does not produce symptoms. GDM unfortunately does not produce symptoms. You can diagnose it by screening for it, which Professor Sunil will ask after some time. But what is important is that if a lady develops gestational diabetes mellitus or hyperglycemia during gestation, there is a chance of developing some complications of pregnancy, which Dr. Pinky will narrate in a raw language. I just mentioned them. Something called eclampsia, or the lady before delivery, the mother before delivery might develop edema, might develop albumin in the urine, might develop sometimes convulsion and hypertension. We call it pre-eclampsia. On it. Don't worry about the term, but try to remember that it can produce some complication. Still on it. Sometimes it can also produce a stillbirth. That means the child born may not be a live child. Sometimes I will come to the person later. Apart from that, it can produce in the mother depression, and also following delivery, there is an impact on the child, on the fetus, on the child, and also the mother. Fetus can develop jaundice. Fetus can develop even a there's a problem. Please try again. It can develop even it can develop the hypoglycemia. The sugar may drop very low after delivery. The newborn child can develop jaundice, can develop the lungs may not be mature enough. These are serious complications. But when the child goes into adolescent adulthood, there is a three possibilities. He can become obese. There's a greater chance that he can become diabetic. And if the child is a female child, there is every chance the female child can become again diabetic during her pregnancy and carry this legacy throughout. We call it transgenerational transmission. I'm using high words, but I'll explain it. From the generation of mine, it can go to my daughter, from daughter to her daughter generation. It's called transgenerational transmission. And many times, this is the cause of more number of diabetics in our country. But what is most important, which my friend Dr. Anil Kapoor has popularized and written about it, talked about it, that this can be a forerunner of diabetes and other non-communicable disease like high blood pressure, heart attack, stroke, etc. So please remember that it can produce uh, diabetes in the offspring. It can produce obesity. The child may become fat. The person may become fat. Can have blood pressure, heart disease, and stroke. And that is that. So therefore, it has been said to prevent the non-communicable disease, one has to prevent the GDM. These are the few things of the cough, Sunil. I would like our people to remember: diabetes developing during gestation, disappearing after, not there before. Number two, prevalence is as high, can be as high as 20%. It's a very common disease in our ethnicity. Number three, it can produce effect during pregnancy, on the newborn child, on the child who develops into adolescent adulthood, and the mother also. There is every chance of the mother who had GDM can become diabetic if she doesn't take precautions to prevent. So therefore, it is danger to the mother who can develop permanent diabetes after GDM, and danger to the child, as I told you, diabetes and other NCD. Thank you,
Yeah.
Sunil, for asking this question. My friend Anil will dilate upon the NCD part of it extremely well because he is an adept in it.
Yes. Dr. Anil Kapoor, very nicely, Dr. Ashok Kumar Das has already actually made the platform ready for you now. And the next question to you, which I have not shared with anyone, but I have written here, it is a non-communicable diseases and GDM connection, or the hyperglycemia and pregnancy, or the metabolic environment of a baby in the womb, and the non-communicable diseases. I feel this has become now one of the most important aspect of discussion, and which has been focused as a kind of primordial prevention of forthcoming disease in the adult life of these children who are born to these mothers. So I want you to try to give the some inputs of yours, because you have got some original work and you have got very in-depth kind of studies on these lines.
Uh, First of all, thank you, Sunil, uh, for the introduction, and also Dr. Ashok Kumar Das for elaborating on the burden and why we need to address the issue of high blood sugars during pregnancy. Now, these high blood sugars can be of two types. One is what Dr. Das mentioned as gestational diabetes, but there can also be women who might have type 2 diabetes or other forms of diabetes which have not been detected previously. And it's very important to distinguish between these two conditions. Now, coming to the consequences of gestational diabetes, the thing is that when a woman, see, pregnancy is a very great stress to the body of women, and it is so it is like a stress test. And if a woman develops hyperglycemia or high blood sugar or gestational diabetes, as we call it, it is a marker that her body is vulnerable to future burden of diabetes. Not only that, but it is also a marker that she might be vulnerable to cardiovascular diseases, hypertension, cardiovascular disease, and stroke. And there are studies that have been done which actually indicate that if a woman develops premenopausal cardiac disease, that is, before they become menopause, if women develop heart disease, there is quite a chance that we might have missed them having gestational diabetes during pregnancy. So, gestational diabetes is a very, very important marker of cardiovascular disease in women, particularly before menopause. Normally, women are protected against cardiovascular disease till they are in the reproductive age and not menopausal. But after menopause, they have as high a risk as men do. But if women develop cardiovascular disease before menopause, the chances are that we might have missed the fact that these women had gestational diabetes. So it's a gestational diabetes is a very important marker for cardiovascular disease. It is also a marker for of course, type 2 diabetes, but the offspring of these women are likely to develop, as Dr. Ashok Kumar Das said, likely to develop obesity because the children born to women with uncorrected gestational diabetes are born large. And these women, these children then retain a lot of fat, and this accumulates over time, and therefore they become overweight or obese earlier in life, and they are at a risk of getting type 2 diabetes earlier in onset. And as Dr. Ashok Kumar Das said, uh, if it happens to be a girl child, then this risk hits her very early on. So she is very, very likely to develop gestational diabetes when she becomes pregnant. And that is why we call it as mother to child transmission. We talk about infections being mother to child transmission. This is not an infection, but this is a risk factor, and there is a mother to child transmission happening. And therefore, if we have to address the burden, future burden of non-communicable diseases, it is very important that we address the health of women during pregnancy. And one of the most important medical conditions that affect women during pregnancy is gestational diabetes. And as Dr. Ashok Kumar Das mentioned, what we are finding is that in India, in urban centers and in big towns and cities, we are seeing almost one in fifth or one in sixth pregnancy being impacted by gestational diabetes. And therefore, if we have to then create a healthy nation and a healthy society, then we have to start by addressing the health of women during pregnancy, because uh, what happens is that the babies, the future health of the baby is programmed when the baby is in the mother's womb. And if that is affected by poor health of the mother, then this child is vulnerable to many of these conditions earlier on in life. And therefore, it is very important to address the health of the mother during pregnancy.
Yeah. Thank you, Dr. Anil Kapoor. So, from this discussion of Dr. Anil and Dr. Professor A.K. Das, I feel one thing is very, very clear, that we are taking care of two generations. If you are controlling, if you are diagnosing a woman with gestational diabetes, if you are keeping the blood glucose normal of a woman who has known type 1 and type 2 diabetes in the preconception phase when she is planning pregnancy, before conception, if you're trying to achieve good glycemic control, that is very, very important for the baby who are being born to these mothers, not only for a good baby at the time of birth, but also for their own future. So and similarly, these GDM women who are likely to become diabetes in future, they can also be protected. So by knowing about it, I feel the message is very loud and clear, that both our experts have emphasized on one thing, that two generations can be protected by taking care of diabetes in pregnancy. So if you're
If
just
I may,
diagnosed,
if I may add something,
please,
it is
please.
as if when women get gestational diabetes, it is like nature is putting a spotlight on them, and indicating to us that these women and their offsprings are very vulnerable for any of these future complications, and therefore it's not only important to address the health during pregnancy, but ensuring that we are able to follow up these women after they have delivered. As Dr. Das said, they might not be diabetic after after they have delivered, but they are very vulnerable to future diabetes. They are very vulnerable to future cardiovascular disease. Their children are vulnerable, and therefore, from my perspective, a very important aspect of this care delivery is ensuring how can we follow these women after they have delivered to ensure that they live a healthy life, because when a woman changes her lifestyle, she changes the lifestyle of the whole family, so it has many ramifications from that perspective as well.
So in short, the society, everyone, every home, every house should be aware of this particular situation, that there is a condition which is called a gestational diabetes, which can and this is a golden opportunity. See, this is the only opportunity you get in the life of a person, that before birth you are trying to protect them from developing disease in the adult life. I feel that is the best gift from any family to their forthcoming generations. And that is why every woman, every man in the house, every grandparent is supposed to be aware of this situation. So every woman who's likely to be in the childbearing age, who's planning their pregnancy, even if they don't have any family member has, no one has in the family has diabetes, even in those women, they can develop this particular disease, and they should need to be taken care of. So the nuts in nutshell, Dr. Anil Kapoor wants to say that every family should be made aware of it, so that we can protect future generation. And in scientific language, we call it as primordial prevention. We call it as primordial prevention. I feel every one of you must be aware about primary prevention, that someone, okay, Dr. Sunil Gupta or Dr. Ashok Kumar Das or Anil Kapoor, you both, all three of you are non-diabetic, and now you should not develop diabetes. You go for regular exercise, keep your weight normal, go for diet control, and go to Kavita Madam and everything, and then try to prevent your diabetes. This is called as primary prevention. If you are not diabetic, if you are preventing developing diabetes in you, that is primary prevention. If you are already developed diabetes, if you are preventing the complication, that is called as secondary prevention. And if you already have got the complication, you have got one heart attack and you don't want to have second heart attack, that is called as tertiary prevention. We are not talking about primary, secondary and tertiary. We are talking about primordial prevention, that we try to visualize the womb, we try to visualize this fetus. And that is why our founder patron, Professor Dr. Shishaya, says focus on fetus for the future. I repeat, focus on fetus for the future. So if you want that India is now the second capital of diabetes in the world, and it should not become first capital, and in subsequent years maybe after 10 years, 20 years, or 40 years, if you want that the diabetes prevalence should come down, you'll have to focus pregnant women and pregnancy as a whole, so that possibly we'll be able to save future generation. I feel we have got wonderful discussion here. Let me now go to the why. Now everyone have understood that why it is important to catch all these women, every pregnant woman for pregnancy, because every fourth or every fifth woman can become GDM or any kind of hyperglycemia in pregnancy. One few of them could be around 10 to 15% maybe pre-existing diabetes, as Dr. Anil Kapoor has said, and almost 85% will be newly detected hyperglycemia in pregnancy. But then how to diagnose and how to screen them? I will go to Piki here, because she has got some original research work done on these lines. Piki, here there is noise in the background from your side. We all are muted. So can you just explain diagnostic and screening criteria?
Yeah, thank you, Dr. Sunil, sir. So it is, as we have heard, Dr. Kapoor and Dr. Ashok Kumar Das, sir, have nicely enumerated the importance of detecting. This is the unique opportunity when we can detect and catch these women young to to prevent complications, not just in the baby, but in the mother, in the perinatal phase, and later on in life. So it is very important that whenever a woman comes to your clinic, antenatal clinic, her urine pregnancy test becomes positive, we must do a DIPSI test, that is the 75-gram oral glucose tolerance test. The patient may be in fasting state or may have eaten anything. It is regardless of her fasting state. We give her 75 grams of anhydrous glucose in 1 glass of water, which is made to drink within 5 to 10 minutes. And exactly after 2 hours, we do a blood sugar test. If the plasma glucose comes above 140, then the woman is labeled as a gestational diabetes mellitus patient. If the blood sugar comes more than 200, then she becomes overt diabetes. What Dr. Ashok Kumar Das was saying, pre-diabetes or pre-gestational diabetes, which is also known as overt diabetes, she may be type 2 or type 1 diabetes. If her fasting, which she's coming fasting, and her fasting plasma glucose is more than 126, again she is pre-diabetes. So we need to catch these women who are GDM. They are parallel to the women who people who are pre-diabetics or having impaired glucose tolerance in non-pregnancy state. So these are the patients on whom we need to concentrate. Nearly 75% will be treated with good counseling, diet counseling, exercise, and if we monitor them regularly, we have to explain to them the complications. Any mother they want, or a couple, they are very keen to have a healthy baby. So during pregnancy, if we emphasize that keeping normoglycemia by monitoring blood glucose levels, you will be preventing so many complications. And we need to narrate to them what are the fetal complications. She can have an abortion, she can have congenital anomalies. If during the preconceptional phase, that is within first trimester or a month before she becomes pregnant, if her blood glucose levels are high, she may develop number of congenital anomalies. The commonest ones are heart and cardiovascular, then neural, then gastrointestinal, all types of congenital anomalies the baby can develop. Other thing is that the baby may be preterm. The baby may be born before due date, and then baby will suffer from respiratory problem, blood sugar will be low, chances of infection will be more, chances of CNS abnormality, that is the neural system is not very well developed. So many complications are there. Baby will have to stay in the nursery for a very long time. They are very prone to infections. Or the baby may be big, macrosomia. We think the baby is so cute. It is more than 3.5 kgs. They look very nice, but they are not healthy. And they are more prone to develop diabetes. When the baby is coming out from the mother's womb, the baby may get stuck. She may have a prolonged labor. We may have to pull the baby forcefully. We may have to apply instruments like forceps or vacuum, and the baby may suffer from so many injuries. So to prevent all these complications, there may be a lot of liquor because of increased glucose level. The baby does a lot of urine and there is increased liquor. So if there's an increased liquor, she may rupture her membranes and she's more prone to infections, endometritis, all those, or cord prolapse may occur. So there are more chances. If everything is normal and blood sugars are not normal, then so many times we see intrauterine deaths, or the baby may be born because of metabolic hypoglycemic problems. We have early neonatal deaths. So to prevent all these things, then lady need to be told about self monitoring of blood glucose, about following up with the physician and the obstetrician. There are so many tests available, so many good medicines available. We need to go to a dietitian, which plays a very key role in the control of blood sugar levels, and emphasize the need of thorough checkup of all the systems. She may have an eye problem, kidney problem, heart problem, blood pressure problems. There are so many types of hypertensive diseases in pregnancy. All those need to be, she needs to be monitored carefully. Antenatal supervision needs to be done to avoid all these complications for the mother and for the baby.
I feel
And
picky.
if the blood sugar level in the first visit is less than 140, we need to tell her that again she has to come back at 6 months, 24 to 28 weeks. Because at that time, the glucogenic hormones produced by the placenta are maximum. And we may catch her at that time. Even when she becomes a diabetic at that time, again we have got time. We need to bring down the sugar levels to normal to avoid all these problems. And if she says you, if the patient is very high risk, she has had a previous stillbirth, a baby has died, or a baby is more than 3.5 kg, she has abortions, she is obese, she is a patient of PCOS, or family history of diabetes is there, then again we need to follow this patient carefully and repeat it at 30 to 32 weeks.
So message is very, very clear from all three speakers that every woman should be screened irrespective of the age, irrespective of the family history, irrespective of obesity, non-obesity, irrespective whether you are young or elderly woman, maybe whether you're 25, less than 25, more than 25, or 30, less than 30, irrespective of symptoms. Even if you don't have any symptoms, this should be screened, because Indian women are almost 11 times at higher risk to develop gestational diabetes versus the Caucasians women or the Western population. So one message is loud and clear. Piki, can you please mute yourself? So one is very important, that every woman should be screened. Now, the second part of it is that these children and who we need to be protecting. Now, we know the importance of diagnosis. We have seen how it is to be screened. We have also, in brief, have said that if suppose blood sugar remains undetected, or if some known type 1 or type 2 diabetes becomes pregnant without control of diabetes, or sometimes they are already on lipid lowering drugs, blood pressure lowering drugs, and they get conceived, then it can be a very dangerous, as Dr. Piki Saxena has already told you. And that is why we have to have a good preconception counseling and care that we'll take at the end. But before this, I feel every one of now Piki has diagnosed that is a case of GDM. Vicky has also said that almost 75 to 80% of these women will do only on nutrition. Rest of the 15 to 20% may go to some medicine, which we'll talk to Dr. A.K. Das. But let me first finish Kavita's role now here. Dr. Kavita, you are you are a certified diabetes educator and a dietitian, and you have got good work in this. Can you just brief in, just give a carry home message, key messages, because we hardly have time now, key messages
Yes.
on nutrition, what they should take, because and the second question to then maybe to Dr. Ashok Kumar Das, or even I'll answer that every woman once are being diagnosed, the first question they will ask you, they will not ask you treatment, they will ask you, mere baby ko kuch ho to nahi jayega, will my baby become diabetic? That's the first question by any woman who is coming to a clinic, and the answer to that is no. Your baby is not likely to become diabetic 100%. That's far sure. Those who are GDM women, the babies are likely to become type 1 diabetes is only 5.7% time, in 5.7% in out of 100, only 5 children born to this mother will develop type 1 diabetes in coming 23 years, and 50% of these offspring born to these mother are likely to become diabetes in next 23 years. So that's a very recent data of 2022, where they have done the 23 years follow-up of these offspring of diabetic mother. So that question is asked, is already answered. But those who are type 1 women, if the type 1 diabetic women becoming pregnant, and if the type 1 is developed before 25 years of age, then the risk is around 4 to 6%. If it is type 1 has developed after 25 years of age in these women, the risk is less than 1%. So don't worry about it. Even if you have diabetes or GDM or pregestational diabetes, not necessarily that your children will become diabetic. And if you control blood glucose well, possibly it will also prevent them in developing type 2 diabetes in their adult life. Now over to Kavita ma'am. What are the key carry home messages on diet?
Yes, as we all know that the government of India clearly mentions that MNT plays a very important role for especially for 2 weeks, and if it fails to achieve the targets, then the pharmacotherapy is started. So when we talk about diet, mainly we all know that pregnancy is being celebrated all over, like in India, and the GDM or the woman is she's being focused to eat more, or maybe eat for two. So the first key home message is what I would like to give. If she is a GDM, we need to focus on the quantity and the quality of the carbohydrate in the diet, what she is going to eat first. And then we need to focus, even especially in the morning times, they usually have hyperglycemia due to insulin resistance. And even a typical GDM usually presents with a postprandial hyperglycemia. So there, I would like to, what we usually do for our patients is like we usually ask them to split their meals. So rather than having a large meal, so maybe a large meal of three or four rotis and with a nice bowl of rice or something. So rather we would split their breakfast, or even split their lunch, and thereby reduce the carbohydrate load. And we would again add a lot of protein in her diet. So we would ask her to add protein in every meal, so whether it is her breakfast, so there we would like to add on maybe a boiled egg, or a nice moong dal chila, or a paneer wrap could be another option. And when she's going to have her lunch, again we need to make sure that her plate has enough of legumes, dal, sprouts, and even a lot of amount of salads, and low fat yogurts has to be added. And in the evening, when there is a time when people love to munch on high fat foods, so there we can add a fistful of nuts, which would be a good quality fat as well. And even night we can give a good amount of dal, or even a khichdi or something which has a good amount of protein. So a good combination of a cereal and a pulse, so that goes a long way. And even we'd like to focus on good quality fats, avoid trans fats, that's very very important. So when we talk about macronutrients, carbohydrates has to be complex carbohydrates has to be focused. All the simple carbohydrates, maybe the sugar, jaggery, honey, has to be completely avoided. And if we always ask them to monitor. SMBG is very very important. So if they see that their blood sugars are increasing after eating poha or after eating rice, so we always ask them to avoid, or even if it may be a fruit, so we always ask them to do SMBG. Secondly, we also emphasize on micronutrient, that is the calcium, the iron, the folate, which is again very very important for the growth of the child. So again they can have skimmed milk, or even a yogurt is a good source of calcium for them. So small
Uh,
frequent meals rather than large meals is mostly advised to a GDM woman.
Kavita, many of the times, like other diabetics, people have tendency of using those sugar-free, various items. You have sugar-free everything here, the sweets, you have soft drinks, you have practically chocolates, everything. And even when it comes to a pregestational type 1, type 2, or a GDM woman, they will have kind of, kind of urge of going to have some sweets. And we know that pregnancy is being celebrated in our country, uh, and for this celebration, nothing else remains, only the sweets. Either it will be ladu, or it will be some other sweets or ice cream sometimes. And this, there are a lot of concepts and in our culture, a lot of faith in on these lines, that try to give the thing which women likes, so the baby, baby should not be deprived of that particular thing when he is womb, he or she is in the womb. So do you have something on artificial sweeteners? Can it be used in pregnancy?
So yes, there are US FDA approves few of the artificial sweeteners which are safe for consumption. So I think sucralose and stevia. Stevia is in fact graded as grass food, that is generally recognized as safe during pregnancy. And every of the all these artificial sweeteners have their acceptable daily intake. So if they are taken within that acceptable daily intake, it is safe for consumption. However, it has to be taken through caution, and especially saccharine has to be avoided because it crosses the placenta, and moreover, aspartame should be restricted in pregnant women who have hyperphenylketonuria patients. And moreover, we should also check upon the calorie content, the fat content of that particular food which has artificial sweeteners. So whether it is a laddu, whether it is ice cream, though the sugar content is low, but the calorie content would be more, and there it would increase the load of it would then later lead to the increased weight. And there's also a few studies which has shown that artificial sweeteners cause gut dysbiosis. So that is why they need to avoid on the foods which has artificial sweetness. Rather they can, if if they have a good glycemic control, they can start on a few raisins, maybe one or two kishmis, or even fresh fruits, no juices, only fresh fruits, and that too not immediately after meals. Maybe after 2 hours or so, they can have a fruit.
I feel very well said. And every woman, if she follows almost 70 to 80% of these women, if they are following all the norms of diet, they will possibly not develop, means they'll be able to control their glycemic target. But what these glycemic targets are, I feel we should know when we talk about control, how much it is to be controlled. So I'll just summarize it, that fasting should be kept as less than 90, and the 2-hour postprandial blood glucose should be kept as less than 120. When we say post meal, it should be 2-hour post breakfast, post lunch, as well as post dinner. So whenever someone becomes diabetes in your home, first thing is to get a glucometer at home, and that glucometer should be a good quality glucometer. Get it checked with your doctor and see that it is giving good quality results, and have got standardized strips and method is being used. And that is why we should try to give what we do in our clinic is, many of times we give these glucometers for these 2-3 months to these women at the time of pregnancy, so they monitor blood glucose at home. So message is, everyone should have a glucometer at home when they become diabetic in pregnancy. They should monitor blood glucose. If they're just on diet therapy without medicine, they can monitor blood glucose maybe 2 to 3 times in a week, fasting, post breakfast, post lunch, post dinner. Sometimes even once in 5 days, 4 days, good enough. But those who are on metformin, possibly they will need to monitor little more. Sometimes maybe post breakfast, post lunch, post dinner, almost daily. And those who are on multiple doses of insulin therapy, they should be monitoring blood glucose, sometimes fasting, pre-lunch, post-lunch, pre-dinner, post-dinner, and 3 a.m. in the night. So they should be monitoring. More you monitor blood glucose, more nicely you can control blood glucose. Because as the pregnancy advances from maybe 10, 12 weeks to 14 weeks, 14 to 20 weeks, 20 to 24 weeks, the insulin requirement and the tablet requirement goes up. And the diabetes also worsens till 38, 39 weeks of pregnancy. And that is why it is not only 1 day monitoring or 1 week monitoring, it should be continuous monitoring of blood glucose regularly. Sometimes we do HbA1c, which is a test which gives blood glucose of last 2 to 3 months, but in pregnancy it is validated to be used only for 1 month. So if
So,
someone who's already on,
Dr. Sunil Gupta, I just wanted to add one thing about monitoring. It is
yes sir,
not just that we monitor to assess how well the diabetes is controlled, but it should also be used as a tool for self learning, because your blood sugars would vary based on what you have eaten and what exercise you have done. So, if you can keep a track of what you ate and what the blood sugars were after that, you will understand that those foods are not good for you. And so it should also be used as a self-monitoring, self-learning and self-education tool. And that is very important, because doctors and dietitians cannot control people 24 hours and cannot look after them 24 hours. People have to look after themselves in diabetes. And therefore, self learning and understanding what is the implication of the actions you are taking, what food you're eating, and what are the consequences for blood sugar. That is a very important part of the monitoring, self glucose monitoring aspect.
yeah, and there is no mathematics there. That's most important, because maybe one person after taking maybe one idli will not increase blood sugar as much as in the other person, and that is why there will be inter and intra individual variations on the glycemic response of particular food as well as the medicine. And that is why monitoring is a wonderful tool, so that you learn that after taking this. And this we have observed, Dr. Ashok Kumar Das sir, we have observed in one of the few of the indoor patients, some of the patients have taken this ice cream, the artificial sweetener related ice cream, and they monitor blood glucose. Those who were doing very well in the indoor patient were doing very well for last 3 4 days. Suddenly the blood that evening the pre-dinner blood glucose has gone up, because they have taken some ice cream from somewhere for someone's some celebration from their patient side or some side, and they have increased blood glucose, though it was a sugar free kind of diabetic ice cream. So I feel we should be very careful in pregnancy, because this is a period where every milligram is important. Even a small rise in blood glucose may affect the baby. I feel now we have completed diet.
Or one
Let
more
me
thing, can I
Yeah,
say, sir, in
yes.
monitoring, we also need to emphasize what is hypoglycemia. Monitoring will also be able to pick up any episodes of hypoglycemia and tell her all the signs and symptoms and how to take care of it. Because it will cause complications to the mother, and we may have an IUD at that time. So it is very important that.
Yeah, you're muted, Picky. Yeah. So I feel the message is again: if your sudden blood glucose drop, sudden insulin requirement, sudden blood sugar drop, if every day you are maintaining say 110 post meal, maybe 85, 90 per fasting. Suddenly, if your blood glucose goes down and it goes to the blood sugar which used to remain 110, 120, suddenly comes to 70. I feel it is an alarm for you, and you should be immediately reporting to your obstetrician that if everything is all fine or not for the baby. I feel we now go to the next part, which is we have still 15 minutes. Dr. Ashok Kumar Das, we have to very brief now about role of metformin. People insulin remains the drug of choice, but then people want sometimes tablets, and most of the OB/GYNs, they love metformin. So can we use any oral drug in pregnancy? Sir, you're muted.
My answer and my practice is that if the diet therapy and the upper body physical activity, walking minimally, whatever we do is not able to control the blood glucose, we must use insulin. I think that will be asking to possibly Anil or somebody, and they'll be giving the answer that 3 insulins approved, and we'll discuss that later. Therefore, the treatment of choice, Sunil, as you rightly said, number one, insulin, number two, insulin, number three, insulin. But there are instances when people do not take insulin. Having said that, I must hasten to add, Pinky will agree with me that the pregnant mothers are the most motivated. Am I correct, Pinky? Because they're motivated for the child. So if we labor hard, they will definitely accept taking insulin. If we fail, And if you find that the requirement of insulin is very high because of the obesity in the mother or very high insulin resistance, one may consider tablets. There are two tablets which has been used in the GM, and out of them, the one which is safer, relatively safer, and been used much more is metformin. I must mention here that metformin has been used in pregnancy by various groups. Number one, there's a condition which exists in the female, especially the young females, called, my dear friends, called polycystic ovary disease. Is nothing big. It is having obese girl child with hairs over the face, excessive hair. We call it hirsutism. They have some sort of a big neck with some sort of blackish discoloration in the neck or in the armpit, as the sign of insulin resistance, that is insulin not working. And if they have menstrual irregularities, and when the ultrasound is done by the professors like Professor Pinky, they find there are cysts in the ovary, that the polycystic ovary syndrome. And the treatment for that is metformin, apart from the ovulation stimulation. So when we give metformin, it has been observed that many of these become pregnant. And metformins continue till we know they are pregnant, and some people nowadays also continue beyond. From those studies and numerous animal studies, it has been shown that giving metformin during pregnancy, during gestational diabetes mellitus, is safe. Now, this has not been done in the human beings. Long-term studies are being taken. There's one study called MIG, metformin in GDM study, mixed study. But I'll cut a long story short because Sunil wants me to brief. I will tell you that there are not very large quality studies. Having said that, today metformin is used in pregnancy by the obstetricians, also by the endocrinologists, diabetologists, and it can be taken. There is one caveat. What is the caveat? The metformin crosses the placenta and it may affect the children. Therefore, there are some people who prevent giving metformin for the first 16 weeks to 20 weeks, beyond which they can safely give metformin if need be. Second issue is that metformin is not approved by the DCGI in our country. Even though it is exists in the Government of India guideline, we have not yet got the approval for it. Recently, in the Europe, about 7 weeks back, they have got approval for using metformin in the pregnancy from a study done on by a company. They presented the data and the WSP data, and that has cleared metformin. I'll put quote unquote cleared metformin to be used from the day one in the pregnancy. But I must hasten to add, in our country, we do not have approval of the DCGI to use metformin. So it will be a off-level use. And you may have to take, if the lady is little legally minded, to take her permission, her family's permission to use metformin. Now, having said that, I must also tell you that metformin use in pregnancy has some advantage. The advantage is the embryo protection. The advantage is diminishing insulin resistance, diminishing the weight, and giving some amount of control. And it has been also observed that metformin given children in the mixed study, metformin in the pregnancy study children, it has been found there were some differences from the children who were not giving metformin but was only on nutrition or insulin, but the final data is not yet available. To make a long story short, I must mention that metformin use in pregnancy in our country is off-level, but it is used. Preferably to use after 16 weeks of gestation to avoid any danger to the placenta, any danger to the child offspring. Third thing, the European studies today have cleared metformin for a larger use, which has not been approved in our country. Final thing, metformin can be used in addition to insulin if the dose of insulin required is very high or there is a very severe insulin resistance. So the bottom line is metformin can be used possibly beyond 16 weeks, 20 weeks with caution. If a PCOS lady becomes pregnant, metformin use you may continue, but I personally change over to insulin. That's the individual choice. And that's my answer to your question, Sunil. If I have answered your question in a short time, because we have got 8 minutes more for Anil and Pinky.
Yeah, thank you, sir. And Dr. Anil Kapoor, anything about insulin? Insulin we do give when it's a pure gestational diabetes. We prefer giving at breakfast, lunch, and dinner. When it's a pre-gestational diabetes, we have to also use, sometimes long-acting insulin also, so that we have 4 pricks per day. That's called as basal bolus therapy. But insulin doesn't cross the placenta. The message is that insulin doesn't cross the placenta, but all the oral drugs which are being used and been approved, or they are being used globally, they cross the placenta. That is why we presume that though the drug which is not crossing the placenta and not entering in the fetal circulation is supposed to be the best. Uh, I feel we have covered the pharmacotherapy part. But if Dr. Anil Kapoor want to say something on monitoring or the pharmacotherapy, it is welcomed. Else, we'll go for the obstetric management.
I just wanted to
Just want
say
Anil to
that
speak. Anil, 1 minute. Little bit about the insulin therapy. People know broadly they can use rapid acting insulin, Actrapid, Aspart, and glulysin, and also Detamir. But little more details, because we get lot of queries, Anil. If you can give for about 2 3 minutes, Sunil.
I think, Professor Das, that part is pretty well covered.
Okay.
What I wanted to say and stress upon is that, pregnancy is a very emotional state. And while
Yeah.
women are prepared to take every possible thing to control their blood sugars and would be willing to take insulin, but it also can sometimes create a lot of stress. And if there is resistance, I would rather prefer for them to have an oral drug like metformin than insulin, because of the simple fact that creating excessive stress will actually worsen the diabetes control and make it more difficult to control. So I think the physician has to find a right balance between what therapy a patient might particularly be comfortable with. Having said that, the other thing that I want to say very briefly, that we focus a lot on the pregnancy part, but it is very important that if we have to get any value of detecting women with gestational diabetes and providing them with good care during pregnancy, it is very, very important that we follow them over a longer period of time after they have delivered. The woman is no longer pregnant, the woman is no longer diabetic, but the risk that she has and the child has is very, very high. And therefore, I always talk about the fact that the opportunity for continuing to educate and empower these women is through linking their own care with the care of the baby, because women after delivery often don't have the time to take care of their own selves, and they forget about it. They are so focused on the care of the child. So what we need to do is to find mechanisms of how the follow up of the women can be done with the follow up of the baby as part of the well baby clinic, linked to the vaccination program. And those are simple things that we need to do. So if we are talking about preventing and doing primordial prevention and primary prevention and all that, then we need to focus on the postpartum period and the interpregnancy period, so between one pregnancy and the other, in ensuring that the women understand the importance of breastfeeding. They understand the importance that the longer they breastfeed, the more they are protected from developing type 2 diabetes and other cardiovascular disease and other non-communicable diseases, that the baby is better off if it is breastfed for a longer period of time, and linking the whole care of the mother with the care of the baby. And so I just wanted to stress that aspect, because that is something that we tend to forget about and is very, very important.
Yeah. Thank you, Dr. Anil Kapoor, sir. Now, Piki, we have heard about most of the things in the whole last almost 50-55 minutes about the importance of gestational diabetes and pre-gestational diabetes, hyperglycemia in pregnancy, importance of diet, importance of oral drugs, importance of insulin, glycemic control monitoring. But one part is remaining in obstetric care. Every woman, once they are being diagnosed or stamped with a diagnosis of GDM, they feel that they are going to deliver a child only by a cesarean section. Now, this is a kind of misconcept, we know, but can you just highlight on this the how these women, and there is another perception which I got it from All India Radio when I was sitting in one of the program. One person asked me, the person who was interviewing me, a non-medico, she asked me there are a lot of tests now being done by obstetrician. Earlier, these tests were not done in the clinic. So why it is important to monitor this irregular sonography and other screening tests in these children in very brief, maybe 2 minutes or so, and then we will have some concluding remarks from all the speakers, all the faculties.
Yes, sir. Thank you, sir. So this is very important myth that most of the people believe that if they have diabetes, they have to be delivered by cesarean section. So I would like to make it very clear that cesarean section is indicated only when the baby is very big in size and we feel that the baby is not going to come down through the pelvis. It is not, there is a cephalopelvic disproportion, or there is some obstetric condition like placenta previa, too much of liquor is there, or any other comorbidities are there. Otherwise, by 38 to 39 weeks, we counsel them that we will be taking you for vaginal delivery, keeping everything ready for if there is a fetal distress or if there's any delay or non-progress of labor, then we have facility to take her up for a cesarean section. And the other thing is, as sir very rightly pointed out, we have to make them understand that they have to come back to us by 6 weeks whenever they are coming for their baby's vaccination. They visit us in the postnatal clinic, and there we do their blood sugar test, check their weight, BMI, BP, and also advise a lipid profile. So linkage of physician. Sir, today I would like to emphasize 3 months back a lady had delivered and we gave her a call. She had come today, and can you imagine her blood sugar was 460. So she was labeled as GDM on insulin because she had come 2-3 days before delivery, and just by chance we gave her a call, and she must have been a type 2 diabetic, and blood sugar fasting was so high. So I sent her to the physician people, and they have put her on insulin, and we got her KFT and FT, everything, eye checkup and everything. So this is how we can pick up and try to avoid complications. Breastfeeding is very, very important. It will bring down her weight, it will bring down calories, blood sugar values, and prevent or delay development of diabetes. And contraception, again, she has to be told that no pregnancy should occur without planning. Preconceptional counseling, interconceptional counseling, as you had earlier mentioned. And next pregnancy should not be very much delayed and should occur after normalizing all the metabolic and glucose levels.
I feel we have practically covered, and some more and more kind of sonographies are being done to assess the fetal well-being. Can you just highlight maybe 1 minute or so
Sir,
how frequently look
after
at that?
at 9 to 11 weeks, we are doing nasal bone and nuchal thickness to pick up any CNS deformities. Then 18 to 20 weeks, we do a level 2 ultrasound for anomaly scan to rule out any congenital anomaly because the baby's organs are nearly made by that time. If she's a type 2 diabetic or she has a congenital heart problem, then we always advise a fetal echo at 24 weeks because that is not picked up at 20 weeks. And then after 28 weeks, we keep on doing ultrasound every 3 weekly to know if the baby is growing at a proper rate because there are chances of macrosomia. And if it's a long-standing diabetes, type 2 diabetes with high BP, then there are also chances of fetal growth retardation. So picking up both these growth abnormalities, too small baby and too big baby, we need to do an ultrasound besides doing a clinical examination. And also the amount of liquor is found to be very much increased, and that can also cause the baby may be turned up. It may be a transverse slide. It may lead to cord prolapse. It may lead to abruptio placentae, that is bleeding. The placenta separates before delivery. So all these complications are picked up by doing serial ultrasound at 3 weeks interval. So that is why these days we have these modalities to pick up and terminate pregnancy if required at an earlier gestation by giving a steroid cover. We can have lung maturation of the baby. So that is why we are now recommending that this is a very high risk pregnancy, and the lady needs to be followed up by serial ultrasound, clinical examination, and the self monitoring of blood glucose.
Kavita madam, last question to you, because we are almost at the end of the program. The very simple answer I want from you about the breastfeeding, and that time, a lot of, again, laddus, the postnatal laddus are very, very common. And the postnatal,
Yes.
many of the women after delivery become obese, and before that they develop second pregnancy, they are already 5 to 7 kg overweight or obese after the first delivery. So can you just talk about the diet, how to prevent this, and
Yes.
how should we be taking care of breastfeeding related diet, lactating
Yes,
woman diet?
yes. So as rightly said by Dr. Picky, that lactation is like a very very important, and exclusive breastfeeding for 6 months has to be for 6 months to 1 year has to be emphasized, and moreover we should also tell them that the diet for during lactation is again very important. That she needs to eat healthy even when she is lactating the baby, so she needs to have good amount of protein in her diet. She needs to again have a good amount of she needs to avoid, especially when you are talking about laddu. Yes, so laddus can be made without good or sugar or honey. It can you she can have a good amount of nuts. Nuts are a good source of calcium and omega 3 fatty acids, so she can add chia seeds, flax seeds, and all the nuts, especially not the dry fruits. I'm not talking about the dry fruits, I'm talking about nuts, especially your badam, your walnuts, and your pista, that should be added. And even like gond, they are good source of calcium which is required postpartum. So yes, it should be added in your diets. And milk products like paneer and skimmed milk should be emphasized for such women. And we also need to emphasize on portion control, because that time sometimes these women they eat a lot. So at the end of like maybe after 6 months, or they tend to put on lot of weight. So again, checking the weight control is very very important, and portion control, healthy eating should be emphasized, and they should be a smart choosing the right food at the right time. Is again, mindful eating is what they can actually again inculcate in their diet.
I feel we are now already covered everything. Finally, I want to ask all of my experts here to just give a final message, a carry home message, one liner message from Professor Ekedas sir, then Dr. Anil Kapoor, and Dr.
I
Piki.
think
Conclude.
I think Sunil, I'll be one liner word, that you can only improve what you measure, whether it is the diet modification or the metformin adjustment, or the insulin adjustment. So you have to measure multiple times. That is the key to a successful pregnancy. Second message is that since metformin has been approved by Government of India in the Yellow Book, and also today European Commission has cleared it to a great extent, if there is minimal hesitancy or even hesitancy to take insulin, one can use metformin. Thank you.
Thank you, sir. Dr. Anil Kapoor, sir.
Yeah, so from my side, the message is that women's health is a very, very critical aspect of a public health program. And it's a very important aspect for preventing NCDs and screening women for hyperglycemia in pregnancy provides us with an opportunity to identify women who might be at greater risk, and then to ensure that not only they but their offsprings can be provided with information and practical advice to ensure that they live a healthier lifestyle. A woman during pregnancy, the entire family is supportive of her. She's emotionally involved with it. And therefore, if we can change the approach of the women, then we can change the approach of the whole family towards a healthier living. And I think that is the message that I would like to give is that this is a unique window of opportunity for addressing the future burden of non-communicable diseases in our country.
Thank you, Dr. Anil Kapoor, sir. May I have Dr. Kavita, the final word from your end, and then we'll go to Picky, and then I'll conclude.
Yes, sir. So I think finally, as a pregnant woman, I would always recommend them to eat healthy, control their weight, and enjoy their pregnancy. It is a precious moment not only for the mother but for the entire family. So they need to enjoy their pregnancy, avoid stress, eat healthy, and of course, SMBG is very very important. And at the end of the day, do meet your doctor at 6 weeks, 6 months, and then once a year. Thank you.
Thank, yeah, thank you, Kavita. Picky, it is now your turn. The final message
Yes,
for all of
yes, sir.
us.
So I think it is very important that any occasion we get in the adolescent clinic, in the infertility clinic, in the gynae OPD, whenever a reproductive age woman is coming to us, we should make them aware and get a blood sugar testing done. And tell them that preconceptional counseling is very, very important. If the baby is healthy, if she achieves normal glycemia during pregnancy, as Dr. Anil Kapoor, Dr. A.K. Das sir, both and you have said, if the baby doesn't come to know that mother is hyperglycemic, then the mother and the baby are both going to be okay, and it's not going to transmit it. Diabetes is not going to transmit it to the future generations. So again, what Sashaya sir says, we need to focus on the fetus for the future to avoid all non-communicable disease. Thank you.
So I feel we have done our job. I'll just conclude by saying, as a president, that every woman who's coming to the ANC clinic should be screened. The best possible test is a DIPSI test or Government of India guidelines test. Just give 75-gram glucose, take 2-hour test, more than 140, diagnose, treat it. Medical nutrition therapy is the base. Go to a dietitian, get it done, or take the consultation from your doctor. Only be on diet control. If you don't achieve 90 and 120, go for the pharmacotherapy. Metformin can be used. In selected cases you may need insulin. Insulin is a drug of choice, but metformin's recommendation is very well said by Dr. Ashok Kumar, can be taken. Follow these women during pregnancy very aggressively through a gynecologist, regular checkups, regular monitoring of blood glucose, regular adjustment of the doses of the drugs, and diet till delivery. And after the delivery, these women should be continuing breastfeeding for minimum 6 months and maximum as much as they can, because longer the duration of breastfeeding is, higher is the chances of protecting these mothers from developing diabetes in future, as well as these children developing diabetes and metabolic syndrome in their adolescent as well as adult life. So breastfeeding is one of the very important part. And these women who become normal after delivery, their blood sugar becomes normal, should be followed by postnatal care on the rule of 6 day, 6 week, and 6 month. And then once in a year, both the women as well as the baby should be kept a good follow-up in a clinic of a gynecologist or a physician, diabetologist, endocrinologist, or even pediatrician, and should be watching them very closely so that we can start some primary prevention strategies in this high risk group in future. Lastly, a message from Professor Shishaya sir. Two messages. One is focus on fetus for future. And Professor Ekedas sometime told me, Sunil, come out with something good Hindi, such quote. So we have come out with such quote: एक जांच से बचे दो जान, एक जांच से बचे दो जान. So we have come out with this new quote for this, for screening of every woman for GDM. I feel with this I stop here, and thank you very much all the fraternities joining here and sharing their experiences. We, on behalf of DIPSI, we are all thankful to you. Of course, we are all from the DIPSI family, but our education part will continue in future. And the final answer for prevention
I think
or
Sunil,
primordial prevention.
to
Sir, you're muted. Sir, you're muted.
the two learnings were, if you have hypertension prematurely, the lady has missed GDM. Anil, thank you for this. And second, was a very significant talk, significant lesson he gave. I must tell you that it was very good, which showed about that the basic of diabetes management, DDM management, is a good follow. Is a good follow. I think every day we learn, as you rightly said. But let us also, Sunil, thank the thousands of people who have joined, because they have made our evening. Sunil, please thank them. And my evening is made because of the audience. And I met my dear friend for after a long, long time. I don't know where he is hiding or I am hiding. Anil, Piggy, I meet very often. And Sunil, thank you very much. We meet almost every day. Kavita, we meet almost once a week.
Thank you.
Thank you very much. And I'm grateful,
Thank you.
Sunil, that on behalf of me, Piki, and Anil, I thank you for having invited us. Kavita also included.
Thank you.
So thank you.
Thank you. Thank you, sir.
Thank you. And now I declare that the meeting is closed and we may conclude here. Thank you very much, everyone.
Anil,
Thank you
see
very
you
much.
shortly. Anil,
Thank
see
you.
you
Thank
shortly
you, sir.
somewhere.
Mostly we can conclude.